Okay, 12:31, and we're resuming. So during the break, our subject matter expert Sharp looked at the TDAP or the tetanus protocol and determined that there were no additional modifications that are needed. The only language changes were in the section that I'm showing on my screen in just a second to modify the age ranges here. So section 8C. So I think with that, we are then ready to motion. Back to you, Committee Member Anderson.
Great. Just wanted to make sure, we did get through everything then? Is that correct?
We did get through all the vaccines, yes.
Okay, great. Well, Committee Member Anderson would like to, so is there a motion to move to recommend the following statewide drug therapy management protocols, version 2 of 2024, for the standard protocol for all vaccines that cover page and assessment and treatment, or the cover page and assessment and treatment. The standard protocol for all vaccines, including managing adverse reactions, the coronavirus 2019 protocol, the Haemophilus influenza type B protocol, the inactivated influenza protocol, Japanese encephalitis protocol, meningococcal containing vaccine protocol, pneumococcal protocol, polio protocol, respiratory syncytial virus protocol, tetanus diphtheria containing protocol, and the yellow fever as revised today to the Oregon Board of Pharmacy for review. Do I have anybody that would be willing to make that motion?
Committee Member Myers, so moved.
Committee Member Gibler, second.
Great. Committee Member Anderson, approve. Committee Member Gibler?
Aye.
Committee Member Myers?
Aye.
And Committee Member Wickenhagen?
Aye.
And for the record, Committee Member Jones and Lee are not on the call with us.
Motion passes.
All right, so the motion for the vaccine protocols passes. So we will now review the, it looks like, tobacco cessation protocol.
Okay, I'm going to, subject matter expert Lehman, can you take the lead and then bring in your other SMEs as needed?
Sure, yeah. Should I share my screen or do you guys have the protocol pulled up?
I'm going to share my screen. Hold on just a second.
And for those of you on the public call, this is mailing B1.
There are only, 2 documents in this protocol that are being changed. So the first one is the patient intake form. And I almost have it shared. Hold on just a second. Okay.
All right, so there were 2 changes that we are suggesting for the patient intake form. The first one is kind of easy. The nicotine inhaler was discontinued and is no longer available. So we've just removed that from the protocol. So question 8 in the questionnaire is asking if the patient has any lung conditions, and that was specifically for the inhaler. So since it's no longer relevant, we are asking to remove that question. And then the other one was question 3. There's an adjustment. We're asking to remove that section that asks if you're currently using or trying to quit a non-cigarette product. The reason for us asking to remove that is because feedback we've received from people who are currently using this protocol is that this has become a barrier when they're trying to treat somebody for smoking cessation when they have a dual user. So we're asking to have that removed so that pharmacists can treat dual users, people who are also using e-cigarettes and Juuls. And then we've moved, if you go up a little bit to the questions up above, if you, in addition to smoking, are you also currently using a non-cigarette product and listing it there, so that can be considered when if you're using nicotine replacement therapy to consider adding in however much nicotine they're getting from their e-cigarettes or other source. And those are the only changes. The other ones are kind of minor things. EX being changed, for example. That's it for that page, that section, unless Elise or Eugenia have anything else to add.
Do the committee members have any questions, comments on intake? No hands, no voices. Okay, I'm going to open the assessment pathway. It's the other document. Back to you, Smee.
So step 2 was removed. This relates back to the question about not allowing pharmacists to prescribe for dual users. So we removed that to allow pharmacists to prescribe to dual users. So that relates to question 3 on the patient assessment form. The other edits were down under prescribing NRT. We added in, if the patient also uses e-cigarettes, to also calculate out their total nicotine dose when you're looking at their nicotine replacement for that. And then, sorry, right above that, question 8 was removed. If yes, avoid using the nicotine inhaler because the nicotine inhaler was discontinued. And then the only other changes, if you scroll down to page 2 to the prescribing of varenicline, we changed the wording slightly to be more consistent with the varenicline package insert, that the quit days can be between day 8 and 35 after initiating varenicline. It used to say after day 7 or up to days 35. So this is just to match the package insert for varenicline. And then under nicotine replacement dosing for long-acting NRT nicotine patches, we added in to calculate out the patient's nicotine from e-cigarettes when calculating out how much NRT they need. And then further down under acute NRT, we remove nicotine inhaler because it has been discontinued. The other request we have on the 3rd page under maximum duration, we wanted to change that from being able to prescribe from 12 weeks to 24 weeks to be a little bit more consistent with current evidence that shows that we can use bupropion and varenicline beyond 12 weeks, and there's evidence that you can have better long-term cessation by extending the duration, so allowing pharmacists to prescribe up to 24 weeks. And then the other one change was under treatment care plan. It used to say documented follow-up within 7 to 21 days, and then phone consultation permitted. We wanted to add 7 to 21 days after the patient starts their tobacco cessation medications. And this was also feedback from people who are using the protocol that sometimes patients don't always start the medication right when it's prescribed. And so adding in the wording that follow-up needs to happen after they start the medication to allow them, in case the patient starts the medication like a month after it's prescribed. Because the purpose of that follow-up was so that we're making sure that the patient is doing okay on the medication, not having any issues. So that made sense to us to add that in. And then Elise did an awesome job of adding in medication counseling points that the pharmacist could use when they're prescribing the medications, as well as further down how to manage withdrawal from tobacco products. It's all pretty basic stuff, but can be helpful for pharmacists as they're prescribing. And that is it, unless Elise or Eugenia have anything else to add.
Right, back to the committee. Any questions, comments?
This is Committee Member Anderson. Those sound like great additions. Thanks for the work.
Yep, thank you.
Not hearing other comments, I think we're ready to go to a motion. too.
Great. So committee member Anderson, is there a motion to move to recommend the tobacco cessation statewide drug therapy management protocol version 2 of 2024 as revised today to the Oregon Board of Pharmacy for review?
This is committee member Gibler, so moved.
Committee member Myers, second.
Great. This committee member Anderson, I approve. Committee member Gibler,
Aye.
committee member Myers,
Aye.
and committee member Wickenhagen.
Aye.
And for the record, committee members Lee and Jones are not present. So it looks like this motion passes.
Yay, thank you guys.
Thank you. Appreciate it.
Thank you.
Thank you. All
Um,
right. Are we moving on to travel meds? Is that?
yes.
Okay, so I'll turn the time over to those. I guess it's B2 in the packet.
Yes. B2 in the packet and subject matter expert. We lost them. Are they here?
So travel meds,
I don't.
Crystal and
Crystal and
Nancy,
Nancy are not here.
they were here.
Huh. Oh.
Did something happen?
Yeah, they're coming. I might go ahead.
I want to talk about the May dates while we're doing.
Okay, while we're waiting, we need to adjust our May meeting date that we had planned. Unfortunately, fortunately, I have to be at a meeting, a national meeting for the boards of pharmacy, and will not be able to attend on that day, which would make a problem hosting this meeting. So, staff member Melvin, can you discuss?
Sure. So agency staff would like to suggest for the committee's consideration either May 8th, May 9th, or May 10th as an alternative to May 15th.
That's a Wednesday, Thursday, Friday.
So we just would like consensus from you today while we have you on this call.
This is committee member Gibler. I'm available on the 8th. I'm in Seattle for meetings on the 9th and 10th.
Thank you.
This is
Committee
committee
member-
member Wickenhagen. I am available all 3 days.
Committee member Myers, I can do any of those days.
Excellent. All right.
Committee member Anderson, I can make any of those days work. Friday is best for me, but I can make any of them work.
So we have a quorum.
Yes.
Because right now we don't.
Yes, so right now it looks like May 8th will be our date because we have to have a quorum and you are our quorum today. So I'll send out an email to everyone on the committee and we will potentially have a new committee member by then, actually.
Assuming the governor's office and the process and the confirmation.
Yes, which it sounds like from what they've told us that will happen by then. And just a note that committee member Lee has decided not to apply for a reappointment. So her position is the one that we are looking to fill. Okay, very good. I will email the committee. Thank you. Back to you. Staff member Davis. They're still not.
We don't have them here. Okay, let's open continuation therapy.
Okay, so you have it.
I'm gonna just pop over and we're gonna have hopefully a quick conversation about continuation of therapy. This was
This is mailing B.
Mailing B. This was a protocol we discussed at the September meeting. And the committee gave feedback. So I went in and made modifications based on your feedback and wanted to see if you like these changes, if you have further edits to what you were provided. So I'm going to be your SME for this one. So questions, comments, further modifications.
This is committee member Kibler. I recall a conversation around damaged
Yes.
containers or drugs. What can you remind me what the conversation even was?
Yeah, no, thank you. Thank you for the prompt. So we received through a feedback form a question of what does the word damaged mean? And so we had a conversation within this group about damaged, and kind of the resulting discussion was that you did not like the language of replace damaged prescription therapy because you're not replacing a therapy, you're replacing a drug or device. Within the original duration of therapy. So I changed all the instances from therapy, or we said medication, to use the same language for drug or device. And then really about damage, you directed us not to use the language of like misbranded or adulterated. And so I created language kind of based on that conversation. The pharmacist must use their reasonable professional judgment, which is a term that's defined in our rules. To determine if the drug or device is damaged. This includes physical damage, like a broken container or spills, chemical changes like discoloration or unusual odors, and damage from exposure to heat or moisture, which can affect the medication's effectiveness and safety. So this was my attempt to make language that is appropriate.
Yeah, I like those changes. This is committee member Gibler. Thank you. That's clear.
This is committee member Anderson. I agree. That sounds much more clear.
Committee member Wickenhagen, I remember the robust discussion and it looks very clear now. Thank you.
Committee member Anderson, can you do the motions?
Yes, I'm actually trying to find that one at the moment.
Sorry,
since we're
this one's
jumping
the-
around.
Yeah, it's mailing B, right under the, where it stated we were breaking for lunch. Look for the yellow highlight.
Yeah, okay. Oh, yep. Thank you.
You bet.
I was going in the wrong direction. Okay, sorry. This is committee member Anderson. Is there a motion to move to recommend the continuation of therapy statewide drug therapy management protocol version 2 of 2024 as revised today to the Oregon Board of Pharmacy for review?
So, committee member Myers, so moved.
Right. Do you have a second?
Committee member Gibler, I second.
Great. This is committee member Anderson. I approve. Committee member Gibler,
Aye.
committee member Myers,
Aye.
and committee member Wickenhagen.
Aye.
Great. And for the record, committee members Jones and Lee are not present. So it looks like this motion passes.
Now, subject matter experts Sharp and Petrusky are here again. So take it away.
This is mailing B2 for those of you on the phone.
Crystal, go ahead and then I'll chime in
Okay,
if I have to.
that sounds great.
Okay, thanks.
All right, thanks for having us back again. So me and Nancy are here to give a few updates on the travel medicine protocol. So first section we have up is a cover page. Throughout each of the documents, we changed acute mountain sickness to be more terminology correct. So we changed that to altitude illness prophylaxis. And then also, as we discussed during the vaccines, the CDC Yellow Book was updated this year. So we updated that citation. And then we really felt like the resources and references were the same. So we opted to just keep references since they had the same information. Okay.
Opening the patient intake form.
Okay. So in the patient information on the top, you'll see that we crossed out any allergies to medications, eggs, latex, if yes, please list. We took that out because there's an area down below for them to actually write out and list that information. So we felt like that was just a duplication. And then, thank you. And then section 5, we had notated that we changed the elevation to be synonymous with the updated yellow book. So that's why we have those changes in altitude there. And then for allergies, we were trying to be a little bit more inclusive. So any known drug or vaccine allergies, and then describe reactions, so giving examples of those. And of course, we're open to any grammar or suggestions from the committee on that. If there's no comments at this time, then for the vaccine medical information, we did a lot of changing to this table. Nancy is an expert in travel medicine, so she educated me on a few different vaccines that we actually didn't have on this chart. So those were added. There's not necessarily a protocol for organ pharmacists to provide those vaccines at this time, but they are added. And then we also have, let's see here. Just trying to make it a little bit more clear for what vaccines were received. For example, like pneumonia, it was a little tight, so we really wanted to space it out and make it obvious what vaccine they had received. We also added RSV, tick-borne encephalitis. Yeah, that was the main change for that section. I think some of our numbering had gotten a little bit off on, if you scroll down.
Yeah, there. 7, 8, 9, 1, 1.
Right, so that should be, sorry, it's hard to tell in track changes. It should be 1, 2, 3, 4, 5. So I think that's what we updated that to. And that was the only change for this document. Nancy, did you have anything to add? Oh.
Yeah, this is committee member Gibler. So when the patient says they're not sure, are the resources that are available, like the yellow book, does that have what they need to make a decision whether to prescribe or not? Let's say, for example, they're traveling somewhere in South America and they don't know if they're going to high altitudes but they could.
Mm-hmm.
So what's the decision on that? Like, or is that real clear in the pathway below?
So in the travel specific section right above that table, they should be listing the countries and cities that they are traveling to. And if they are not sure, the pharmacist should be looking into the elevations of those cities to determine if they are eligible for altitude illness medications. And that information is in the yellow book.
Yeah, okay, perfect. Thank you.
I'm going to open up the assessment treatment care pathway.
Thank you. All right, so first change, citation to the 2024 yellow book was updated. And then as we scroll down, there was just some grammar or verbiage that was changed throughout the document. So initially this document had read like for malaria prophylaxis begin 1 to 2 weeks prior to travel. We really wanted to indicate the malarious area. It may not be indicated for all sites or destinations that they're traveling to, but really being specific on the risk area itself. So you'll see that throughout. And then we also changed risk area to malarious area just to be a little bit more specific. Let's see here.
Is that term what the CDC is using? Malarious?
Yes, it's
Okay.
kind of a weird word.
Yeah, I would think, malaria risk area, but if they're using that term, that makes sense, I guess.
I mean, we could change it. I mean, it is kind of, it does, I mean, the point is that the person could be traveling someplace else for 2 weeks before they go to the area that has malaria. So, malaria risk, how about malaria risk area? I think that sounds better. I agree with that.
Committee members, are you okay with that change? I will just make a note to make that after the fact. I'm not going to sit here and try to do that throughout the document.
This is committee member Anderson. I'm fine with that change.
Committee member Wickenhagen, that seems fine.
Okay. Can't even spell it. That's what a malaria. M-A-L-A-R. Yeah, I like the change. Okay. Okay. I think we had left off here.
So just a few minor things, being more specific, changing CDC guidelines to CDC Yellow Book to be more specific. Once we get to section 3, just using altitude illness instead of acute mountain sickness, because that's the more updated terminology they're using.
Sorry, this is committee member Myers. I'm still struggling over the entering malaria risk area. It reads better to me entering a malaria risk area if we're grammatical. Not to be picky, but
Well, I guess
is that wrong
you
or
would have,
right?
well, I guess you would have discussed where they're going. So you would know their itinerary already. So you're not leaving it up to the patient to say, oh, I think I'm going to a risk area. It could say the malaria risk area, right? It's not the patient. The patients aren't deciding when they want to take it. The pharmacist is going to say, as soon as you are 1 to 2 days away from X country, you need to start taking this.
No, I understand. It's just
Yeah.
grammatically, it doesn't roll to me.
Okay. The malaria risk area. That's fine.
Should be
Sure.
Sarah.
That
Or
works.
A.
Yeah. Feels like it needs a pronoun. Or not a pronoun, yeah.
I think it still should be the, because that's, yeah, because, yeah, A is less specific.
I'm good with that.
Okay.
Don't remember where I left off. Yellow book. I hadn't gotten there. Oh, we are at acute mountain. All right, here.
And then we had updated the instructions for acetazolamide to be more congruent with what's in the Yellow Book. So that's why that change is there. And then throughout the document, another CDC Yellow Book update, some grammar changes for motion sickness. Just there were a few extra capitals that didn't need to be in there that were fixed. And then as we get down to screening for protocol contraindications, you actually might have been. Can you go up just a little bit? Sorry. Okay, so me and Nancy were debating about this. So initially this had been screened for contraindications, but we decided to change this to protocol contraindications. because I think there were a few things that weren't technically contraindicated, but for this specific protocol, we wanted to include that. And then number 4 for doxycycline, we reviewed the yellow book again, and they basically said that doxycycline was contraindicated in all pregnancy, not just second or third trimester. So we updated that. And then for acetazolamide, we added a hypersensitivity to acetazolamide or any excipients, and then information about it being a sulfonamide derivative.
Should this be acute altitude illness? I don't know. What's the correct term? It still says mountain sickness.
Yes, we missed that.
That's okay. I caught it.
Thank you.
All right, and then if we keep scrolling down, so under promethazine, we just grouped asthma as an example of a condition because basically that groups into section C anyways. Section 4, diamond hydronate. I mean, neonates are less than 7 years old, so we figured we would get rid of that duplicate. Same with diphenhydramine, that was duplicative. And I think that's all that we had for this document.
Any questions from the committee?
This is committee member Gibler. I'm just wondering if pregnancy was excluded in our STI protocol.
This is
That one
committee
was-
member Anderson. It isn't. I actually was looking into that as we were kind of talking, and it looks like it's somewhat debatable.
Yeah, we're wrestling with this, and I wonder if the CDC did that because there's alternatives, and they just said don't give it in pregnancy. I'm trying to remember what we
I think they're talking about the protocol that they discussed earlier today.
Yeah.
No, I know, but I'm trying to figure out whether it's an absolute contraindication period, or, you know, if for travelers there are alternatives. But I guess there's alternatives for STIs as well. Let's see.
We can go ahead and finish this discussion, and then we need to reopen the other protocol. We can do that after this.
Okay. Yeah, there's some of this is old. There's a FDA has a statement about it. Okay.
Any questions on the assessment and treatment care pathway? This had already accepted the altitude and illness change, and I didn't go back and unaccept it. So I think that was the only change on this document. Correct me if I'm wrong.
That's correct.
Next document is the provider facts. I went in, I think I made the change from immunization to vaccines. We call them the vaccine protocols. Immunization is the series of what happens when you get multiple vaccines. So just for consistency, I had changed that.
Okay, great.
That's good.
Otherwise, I think it's altitude illness that was changed here.
Right. And then for vaccines administered, I know on the intake form, we had more vaccines that they could have received in the past, but we only listed vaccines that have an Oregon pharmacist protocol for this document.
And an update to the yellow book. 2024.
Will that OAR change?
No, that's the new one.
Oh, okay.
We'll hyperlink it once it's up on the web, but yeah, that's the new number. Any questions on the provider facts? And the last one is the patient visit summary.
So we had altitude illness again. It looks like we changed verbiage from immunization to vaccines. I think with some of the changes, we were trying to get all of this on one page, hence the reason why we removed one of the
Lines.
sections there,
Mhm.
because we had so many and we figured we probably didn't need more, but we're just trying to keep it on one page. And that's it.
Any questions from the committee? Okay. Committee Chair Anderson.
All right. It looks like, yeah, we're all done looking through the travel meds. So is there, this committee member Anderson, is there a motion to move to recommend the travel medications statewide drug therapy management protocol version 2 of 2024 as revised today to the Oregon Board of Pharmacy for review?
Committee member Gibler, so moved.
A second?
Committee
Committee member
member-
Myers.
Oh.
Second.
Great. This committee member Anderson, I approve. Committee member Gibler,
Aye.
committee member Myers,
Aye.
and committee member Wickenhagen.
Aye.
All right. And for the record, committee members Jones and Lee are absent. So it looks like this motion passes.
Great.
Are we all
We
through
are at
everything?
short.
Yeah, so staff member Davis, I just need clarification. Would the committee like for me to try to get back on the line our SMEs for STI PEP to discuss doxycycline and pregnancy? Yes, I know.
This is committee member Wickenhagen. I don't think that it's necessary. We know it's bad.
This is committee member Gibler. I don't think that's necessary either. It doesn't look like it has been identified by the CDC and for STI prophylaxis, whether that population should be targeted or not. Have to be treated in some way somehow if they get an infection. So what are we going to do? So I think either pharmacist discretion but I don't think we need to change the protocol.
Yeah, I'm looking at the FDA statement, and it says the use of doxycycline during pregnancy has historically been discouraged unless other drugs are not likely to be effective or are contraindicated. So I think that's the way out.
Thank you, Nancy.
Sure.
All right.
Yeah.
Oh, I was double working. Okay, I think we are now ready to go back to the beginning of today and do the short acting opioid antagonist protocol, and our subject matter expert, Katie Abbott, has joined us. So thank you for being super flexible with your time today, Katie.
This is mailing A1. Katie, you're on mute. Could you come off mute, please?
Yes, hi, this is Katie.
Hi.
And then I just want to remind the committee, I don't want you to feel rushed, but I do want you to know that we will be ending at 2 o'clock today because we will lose quorum at 2 o'clock. So if we get into this and it's taking a long time and we don't think that we're going to be able to get to the point of motioning, we will just pause and pick this back up in May. But if we are close and we feel like we can get through this conversation, it would be great if we can move it forward, but it is not, we recognize that we may have to pause this conversation depending on the amount of time it takes. So that was why I moved it to the end of the day, because pharmacists already have a way to prescribe naloxone. This is just providing them with another tool in their tool belt. And so it wouldn't have impacted, let's say patient health and welfare and safety by not being able to discuss this, but it does give pharmacists yet another tool. So
also, this is staff member Melvin. We did not have anybody sign up for public comment today, so we don't need to have public comment at the end of the meeting.
All right. Back to you, subject matter expert. Yeah.
Hi. Yeah, I am not 100% sure what. Do you want me to just walk through this?
Yeah. Yes, and I'm happy to walk through and then have you pop in because you know all the conversations your group of SMEs had. So this protocol looks very similar to what you have seen with other protocols. There are some additional statutory language and authority that pharmacists have in Oregon related to prescribing short-acting opioid antagonists. I understand that the group of subject matter experts, when creating this package, wanted a lot of these documents to be optional in ways that we have not. The committee, when I say we, the committee has not traditionally made like something like a patient intake form an optional form, or the provider fact sometimes is optional. Patient information you could also make optional. So I just wanted to point out kind of at the beginning that this is essentially creating another pathway for pharmacists to prescribe naloxone and other types of short-acting opioid antagonists, but they wanted some flexibility and whether the documents were required or not. I did look in to see if we could put this drug on the formulary list because it is one of those drugs that you really kind of go like, is there really any harm if a pharmacist was to prescribe and if they were to prescribe 20 boxes to somebody, like is there any reason for limitations and boundaries? And while I do think it would fit beautifully with the formulary protocol, there's one hiccup is that a formulary item, you must have a diagnosis from a provider. And so that would make it very hard to actually utilize the drug if it was only on the formulary. So this protocol opens doors for pharmacists to be able to prescribe without a diagnosis for public health. And so you can see the committee recommended no limitation on quantity or refills, or the subject matter experts, and then they've listed out the resources that were used to develop the protocol. Any questions from committee members? No questions, no hands. I'm going to move to the next document. So the next one is the patient intake form. Again, at the top, this says optional, may be used by the pharmacy if desired. And so it just asks like 3 basic questions about experience an overdose or being likely to, knowing someone who might experience an overdose, and would they like a kit, and do they have any allergies to the products that they know of.
This is committee member Gibler. Why don't we just ask, do you want naloxone? Or something like that, instead of, like, if they say no to number 1, like, yeah, we're still going to give them the naloxone. Then we go to number 2, we still would give them the naloxone. It's basic. I'm just not sure. like what we're trying to what we'd be clarifying with those questions, because I want it really obvious that you can be, just one it yourself, one it for a friend, one it for your business.
Yeah, this is Katie. Yeah, Andrew, that's exactly my thought was that we didn't even need this form. But it could still be optional, I suppose.
Yeah, I think just this committee member Gibler, just like what you have with the number 3, which would be the only question we need to ask. Only because, like in the past, we've had issues with pharmacists just being extra conservative about how they prescribe this, making sure it's for the person and the individual, and I just, any way we could be more flexible, and helping the pharmacists be comfortable being flexible.
Do you want to retain the medical history question?
Well, that, I mean, that only applies if it's for themselves or for perhaps a loved one that they're very close to. But I'm just not sure if that's going to be applicable in most cases as we try to get this out into the community.
This committee member Myers, I've got kids in college and I would love for them to carry naloxone. I have no concerns about what they're up to, but they're in a dorm. What if somebody's messing around down the hallway and accidentally gets a fentanyl overdose?
Yeah, exactly.
None of this applies to that situation.
This is committee member Anderson. Do you mind if we go back to that discussion you brought up at the very, very beginning of this about the list of devices and medications that we've never added a medication to just the list of things pharmacists can prescribe? And you're saying that we need to have a diagnosis, but why do we need a diagnosis for naloxone, I guess?
We only need it if it's on the formulary list. The formulary by law requires it having a diagnosis. But a protocol, which is what we're proposing, doesn't have to have a diagnosis. You give the pharmacist parameters by which they can prescribe, and you can make those pretty broad, like you can make it very much like, are you requesting this, and almost make it to the point of a formulary item. But for the formulary based on law, it says a pharmacist may prescribe and dispense a drug or device included on the formulary established under subsection 6 if the prescription and dispensation is pursuant to a diagnosis by a healthcare provider who has prescriptive authority and is qualified to make the diagnosis. So the formulary list has always been limited to things that are post-diagnostic.
Oh, interesting.
So
Okay.
none of the vaccines are on the formulary?
Correct. They're all in the protocol compendium.
I see.
Yeah. That's all the protocols you've considered are all protocol compendium. The only things on the formulary have typically been devices like blood glucose monitoring supplies, and because we can get a diagnosis, the patient has diabetes, and so we will give them that, or INR testing supplies, and they have a diagnosis for, being on medications to thin their blood or whatever. So yeah, the formulary has to have the pharmacist can't prescribe. You can put it on there, but that doesn't allow a pharmacist to prescribe it just to anyone. They would have to have a diagnosis. So
Okay.
this is like
Thank you.
this is your other lever is, well, then we'll make a protocol, and you can make it a very bare bones protocol, but a protocol. So do you want to
Committee member Wickenhagen, I mean, you can get it in vending machines for free, so I'm just.
Yeah. You can, but that's not via pharmacist prescribing. So
Right.
that's just a different lever. So do you want to just remove question 2, or do you want the pharmacist to collect that information if they're prescribing and the person who's getting it knows they're allergic to naloxone? Then do you want them prescribing it?
Yeah, this committee member Anderson, I feel like, yeah, there's like only one question of, do you want this and how much?
That's fine. Or
So
other
this
committee
is
members?
committee member Gibbler. Is it Smee Yabit? I'm just kidding. Katie, are you okay with Katie and I go way back. Are you okay with just that one question? Would that still be?
Yeah, actually, I think the third document really is just that question, which is why I didn't really want the other one. To me, this is just saying, do you want it or not? And then providing the pharmacists with the options, the treatment options below, and some education that they could then share with patients, and also hoping to allow them to feel more confident in prescribing it and using.
I like it.
So I opened up the assessment and treatment care pathway. So any further questions on the intake form or any questions on the treatment care pathway? Like I said, a very simple document.
Yeah, Jen, this is committee member Gibbler. On the intake form, just the information on the top is incredibly, it's all for the personal, it's all personal to the person requesting the short-acting antagonist. If they're requesting it for just to be available in case they need it, which will be maybe many people, if they're requesting it for their workplace or their school, is there an option just to say NA, not applicable, or can we do that? Or is
This is committee member Anderson. Yeah, I'm wondering if we like separate it out by like, what is the bare minimum stuff we need to write a prescription? And then, the other stuff is like, if you would like to give us this information, you can. But you don't have to.
I agree. That would be nice if we could do that.
I mean, so given that you could
Just make like an optional section for this.
really just need, I'm trying to think of the elements of a prescription. Sorry, I'm like going back to the law in my head. So give me just a second.
Sorry.
We do have a list of things that must be know which rule it is off the top. Name of the patient, full name for controlled substances, name, strength, dosage, forge of the substance, directions for use, date of filling. Okay, so name of the patient. That's the bare minimum. I mean, every pharmacy is going to also need date of birth just by their computer system, but name of patient.
This is Katie. For the PEP prescribing or the STI prescribing, oftentimes they don't have a patient's name if they're doing it for like the partner. So do we need a name?
Yes, Staff Member Davis, that's a special exception in law that you don't need a name, and that's specific to ETP prescriptions.
I guess I'm wondering if there is naloxone callouts because we are just giving it to people without a label. So do we even need any kind of prescription?
This is Committee Member Anderson. Yeah, I mean, it is over the counter now, so they can just purchase it that way. But
Well,
I
only
think
one
this.
formulation is, you know, this
Oh,
gives
right,
access to
right.
several
That's a good
formulations.
point. Yeah, that's a good point. But I guess I'm going back to the, like, if you want a prescription though written for it, like the pharmacist, you know, would have to write a prescription. I mean, hopefully this would also make it so that you could bill insurances
Right.
as well.
When you write the prescription, then you can bill insurance, and that's important for a lot of people.
This is Katie.
Amen.
I guess that, sorry, Andrew,
Oh.
I guess that makes sense for, you know, the college kid for down the hall, you know, they would probably purchase it over the counter. They wouldn't request a prescription.
Unless they don't want to pay for it, you know, then it's always an
Mhm.
option to run it through your insurance. And that, as a committee member, Gibler, it's just a thought that we want to create this avenue for easy prescribing of the products, so they have that option to access to different formulations they may be more comfortable with, and being able to not pay too much out of pocket, because the OTC can, I'm sure, can still be quite expensive for most people.
So what I'm hearing is, we can make, I mean, we can put, the form's already optional, but you can optional additional information and then just leave name and date of birth. Like what is not optional?
This is Committee Member Anderson. I think just the stuff that is the bare minimum for a script. So a name, and you know, if you don't need.
Right.
Sorry, if there was somebody else, I was just gonna say name is, I think, the only thing you need.
And even committee member Gibler, even if you just say name of person requesting naloxone, since it may not be for themselves in many cases, or short act SOA or whatever we call it nowadays.
Not gonna be able to make this pretty with formatting, but I can.
Yeah, that looks good.
But you get the idea.
Yeah, I get the idea.
Optional, like, right? And then the only thing that would be required is today's date, name of requester, and would you like them, and how many would you like?
Perfect. That's exactly what I want, committee member Gibler.
Do other committee members agree with this direction?
This is Committee Member Anderson. I agree.
Committee Member Myers agreed.
Committee member Wickenhagen agree.
So then on the assessment and treatment care pathway, you were provided with this document prior to. Did anybody have any modifications or edits that you wanted to see made to this document? Discussions?
Yeah, committee member Gibler, I just don't know number one there. I'm not sure. Again, is this a question? When would they check off no if they're requesting the SAOA?
Working in community pharmacy for as many years as I have, nothing surprises me, but I would say it would probably be relatively rare, but.
If it's relatively rare, I just put the yes first in the green on the left and the little red box that says no on the right somewhere, just so in order of kind of your visually how you'd fill something out. if you don't mind me being picky.
Oh, I'll flip that. Okay. I'm going to open up the next document. This one is also optional, and it just lists out all the different formulations that could be prescribed via this pathway, with fill in the blank for how many doses and how many refills.
And this is committee member Gibler. This will still, as I understand, give flexibility depending on insurance coverage. Since there might be quantity limits, I suppose with some payers, I don't know if that's the case or not, but it looks like everything's left blank, so pharmacists can be flexible just to make sure it goes through insurance if that's a possibility.
Yep.
Okay.
Okay. Then the last document, the package, is a provider fax, if so desired. It fax the patient's provider. This is an optional document, and it just lists the same things that were on the prescription. And then for I'm missing it. There was a document included in your packet that was a PDF of the OHA, how to administer naloxone, that was
On our website.
yeah, that was that had been recommended by the SMEs as potential education document that could be provided, to written documentation that could be provided.
No, PFAP, right there. Scroll down to the
Any comments, questions? I'm trying to get to the agenda so I can open that document.
No.
I said it was this one.
That was last year. Go back.
Oh, I missed 2024.
You're right there.
Man, it's right there. Got it.
It's page 21.
That could be included in the protocol as potential education. It's page 24.
This is committee member Gibler. Since this is optional, right?
Yes.
So I think on that first sheet, it doesn't say optional next to this on the bullet point at the very beginning of this protocol. Utilizes standardized patient information, and we should probably insert optional.
Got it.
Because they'll come, I'm sure nalmefene will also come with a product patient information insert that will be more appropriate.
Added optional there.
Thank you.
I apologize. When I am in this setting that I am in, it doesn't open PDF documents the way I want it to.
Your page number right there on that side. On 2.
Here it is. Just had to find my bookmarks. So this was like how to train somebody to use naloxone. Any comments, questions from the committee? And I did just want to bring up something that our subject matter expert mentioned. So when a pharmacist prescribes one of these pursuant to the protocol, because they are the prescriber, they would then qualify under the labeling exemption that was in 2023 Senate Bill 450 to not have to even label the product, to give it to the patient, as long as the pharmacist is doing the prescribing and then personally dispensing. The same goes for all other healthcare providers, but it's just not typical that a pharmacist is prescribing and dispensing a product, but this would permit them to do that, and then not have to label it. They could fall under that exemption.
This is committee member Anderson. Do we actually say that somewhere then? That might be nice to just kind of remind folks.
Yeah, committee member Gibler, I agree. I was wondering the same thing and I didn't notice it.
I think these subject matter experts have been very patient. They had this ready for October meeting and that we didn't have a meeting. And so that bill, I can't really remember the status of it and where we were at. And we maybe didn't understand the full ramifications yet. So we could add language.
Cite the rule.
Yeah, we'll cite the rule is kind of, we can add I probably cite the law because the law is much clearer about what the rule just says, cite the law. So we can put something like here, like pursuant to ORS 689.808. I don't quite know the number yet, but I'll look it up. It just gave these all numbers.
You want me to give you the numbers?
This is committee member Anderson. What if we put that down by the prescription label section?
Okay. Let me grab the language because it might just be easier. It has to be a nasal spray, so the exemption doesn't work for injectable and some of these other things. Do you want me to put the language, or do you want me to put where's labeling? Sorry.
Well, I think it's even more important to put this down than if it's just nasal spray. Might be a misunderstanding people have.
Maybe you want its own section, like here, like labeling.
Labeling requirements. Just to note that standard labeling requirements apply except for nasal spray per ORS 689.813. Something to that effect.
We have a labeling rule. I'll find it real quick. Something. That's institutional labeling.
6410, that's emergency.
It's lower. Except for something like that. Standard labeling requirements apply per, I'll find the rule number, except for short-acting opioid antagonists in the form of a nasal spray that are personally dispensed by the pharmacist at the pharmacy per ORS 689.813. Just double checking my rule number. Believe it or not, I don't have them all memorized.
Institutional division 3, it's 19.
Yeah, but this is all.
Yeah.
Yeah, it's 11:30. Okay. Does that sound good? Committee.
This is committee member Anderson. That looks great. Thanks for including.
Thank you.
This is committee member Wickenhager. Wunderbar.
Are you ready to motion?
I am ready to motion if others are. I believe this one's at the top of the page. Is that correct?
Yes, this one's A1.
Great. So this is committee member Anderson. Is there a motion to move to recommend the short-acting opioid antagonist statewide drug therapy management protocol version 2 of 2024 as revised today to the Oregon Board of Pharmacy for review?
So moved. Committee member Gibler.
Do I have a second? Great. So this is committee member Anderson. I vote yes. Committee member Gibler,
Aye.
committee member Myers,
Aye.
and committee member Wickenhagen.
Aye.
Great. And as for the record, committee members Jones and Lee are absent. This motion passes.
Staff member Melvin, really quickly, just to confirm I heard that properly. Committee member Myers seconded that motion. Is that right?
Yes.
Yes.
Okay, thank you.
All right. Are we going to try and get anything in the next less than 20 minutes?
Yes, I have just enough material to get done in 20 minutes, maybe less.
Great.
Staff member Davis. So the last couple of things we wanted to discuss with the committee were a couple of protocol feedback forms that we've received, and we just need some direction from the committee as to how you would like to proceed. So this is going to be mailing C1, the first one that I'm going to discuss right now for sake of time and putting things in order for different things. So there was a request to get an Mpox or monkeypox protocol. The person requesting said like OHA used to have. I included my communication back to the requester that there was never an Mpox protocol for pharmacy. That was always a public health protocol that's used by local public health departments. But wanted to find out if the committee was interested in having our subject matter experts for vaccines work on a possible monkeypox protocol.
This is committee member Anderson. I am fine with having that worked up, except I'm just curious if there are limitations, as in like are only public health departments able to get that vaccine in? And because I guess I thought it was somewhat restricted, like there weren't very many and you had to kind of request it specifically. Am I wrong about that?
I do not know about the availability of it. I do know I had some initial conversations with the OHA when the vaccine first came out, and they were looking at utilizing pharmacies as a mechanism for distribution. I don't know if committee member Gimpler might have any additional information related to monkeypox.
I don't right now. I don't have anything currently for the last several months, but at the time, I believe what committee member Anderson was mentioning was it was a special distribution from the feds to the state. And I could be wrong, and that may have changed. So maybe what I'll do is look at some of my contacts and see if pharmacies are able to purchase it now. Unless the SMEs want to do that.
I think they just wanted some feedback on if the committee would be interested in entertaining a protocol, and I'll just give them the caveat to double check that pharmacies are even able to order or obtain it prior to, working on developing something like that.
That makes more sense. As long as they can get it I personally, as committee member Gibler, would be fine with that expiration and maybe a proposal.
So it sounds like we have people in favor of potentially developing one, assuming that pharmacies are able to order the product.
This is committee member Anderson. That's, I think, what I would go for. Yeah, that they first need to verify pharmacies can obtain it. And then if they can, then absolutely work it up.
All right, and then the other item that was brought up was related to a request to add continuous glucose monitors and related supplies to the current formulary. Talked about the formulary list earlier. It's pursuant to a diagnosis, as it only lists diabetic blood sugar testing supplies currently. I did some research on this request and just wanted to make people aware that this is a request that the committee has seen before. I'm going to find my notes just so that I'm actually speaking correctly, accurately for the record. So the committee looked at a concept. So it was it wasn't a protocol concept. It was really to add it to the formulary. Back in October of 2018, the submission had come in August of 2018. And it was to adding the CGM devices and supplies to the formulary list. This was very, very early in this committee's meeting. And that at the time, like the first CGM had just been approved. Like it was pretty new. Like there was like one on the market. And the committee chose to discuss CGM as a separate item from blood glucose testing supplies or blood sugar testing supplies, just because they wanted to make sure they had a separate, robust discussion. And at the time, the minutes reflect that due to the volume and complexity of data provided by the readings, a pharmacist may not have the time or experience to manage the patient appropriately, as CGM was traditionally reserved for complex patients, again, at that time, and that the pharmacist could issue a prescription for a patient if continuation of therapy was warranted. So they looked at it as, like, if the patient has a prescription for one of these CGMs and they run out of refills, the pharmacist could just initiate a prescription under continuation of therapy and not utilize the formulary. So they did not want to move this forward to the formulary list. Since that time, a lot has changed. So like I said, we got the submission in August of 2018. They talked about in October of 2018. The first product was FDA cleared on March of 2018. So this was coming in just a few months after the first product. Now there are 10 plus products that are cleared, mostly by 2 different manufacturers. And it's kind of like the 4 level, the 5 level, the 6 level, so they've updated and modified their products to make them have more bells and whistles, I would say, from looking at a lot of the submissions. These sorts of products go through an FDA pathway called the 510K process. And so there's one product that's like the initial, kind of think of it like the brand name drug, right? It's the initial gold standard. And then each product that comes after that doesn't have to get that initial approval. They just have to say their product is essentially equivalent, and the FDA will give them an approval under that. They have to submit a ton of paperwork and prove all the things, but it's called a 510K process. So I looked up all the items that were 510K approved. Then there's 2 different categories. There's integrated continuous glucose monitoring systems that are not for use with automated insulin delivery systems. And then there's other ones that are for use with insulin delivery systems. So some of these CGMs, they track the patient's blood glucose and they automatically send to the insulin device this is the dose, or this is your correction factor, or whatever, and it doses the insulin. So there are two different subcategories under the header of continuous blood glucose monitoring systems. And I think I'm done talking. I just wanted to bring this back to the committee, give you a little history, and then ask, is this at this time, now that we're much more familiar with CGM, it's pretty standard in the community pharmacy, you know, to have patients that are receiving these. Again, if it goes on the formulary list, the pharmacist would only be able to prescribe pursuant to a diagnosis. And this kind of falls similar to blood glucose testing supplies, where sometimes in the pharmacy we receive a prescription for the reader, but not the sensor, and then the sensor, but not the reader. And so it's kind of trying to assist with some of those nuisance phone calls of, we have one part, but we don't have the other part. So back to you, committee member Anderson, for some committee discussion.
Sure, this committee member Anderson. I think you're spot on with that. They're kind of pretty common at this point. And I would have no problem adding it to, it's not the formula. Yeah, it is the formulary list. Sorry. I'm getting confused. Sorry. I don't have a problem with adding that. Especially because it does fit pretty closely to the other blood sugar testing supplies that are already on it. So I like that idea. How do others feel?
Yeah, I agree. This is Committee Member Gibler.
Committee member Myers, I agree as well.
Committee member Wickenhagen, I agree as well.
Awesome. All right, is there any discussion? This is committee member Anderson. All right, then, is there a motion to move to recommend the addition of continuous glucose monitors and related supplies to the list of formulary of drugs and devices to the Oregon Board of Pharmacy for review?
So moved, Committee Member Gibler.
Have a second?
Committee member Myers, a second.
Great. This is committee member Anderson. I approve. Committee member Gibler.
Aye.
Committee member Myers.
Aye.
And committee member Wickenhagen.
Aye.
And for the record, committee members Jones and Lee are absent. This motion passes.
My goodness,
All right.
we made it through that. Congratulations. That's great. Thank you, everybody. You guys did a great job. We have covered everything else that we had on our agenda today. So you guys can get your 5 minutes back or 6 minutes back. We just need you to adjourn. Yeah.
All right. That's great. This is committee member Anderson. Is there a motion to move to adjourn this meeting at 1:54 p.m.?
So moved, Committee Member Gibler.
Committee member Myers, second.
Great. This is committee member Anderson. I move yes. Committee member Gibler.
Aye.
Committee member Myers.
Aye.
And committee member Wickenhagen.
Aye.
And for the record, committee members Jones and Lee are absent and this motion passes. We are adjourned.
Thank you all
Thanks,
for your
everyone.
flexibility.
Thanks.
Take care. Bye-bye.
Bye.